Great. I think we can begin. So, thank you so much, everybody, for joining us, our esteemed speakers, Eric, and the audience. My name is Resham. I lead the Public Health Impact through AI initiative here at PATH, and it's an absolute pleasure to share the space with each one of you. Welcome to the second session, the second webinar of the AI and Public Health Expert Dialogues on Strategy, Governance, and Ecosystem Transformation, co-hosted by PATH and OECD, and convened under the PhixAi initiative. For those new to PhixAi, it's a flagship initiative at PATH, a platform to accelerate scaling of innovations at the intersection of AI and public health to sustainably achieve universal health coverage and health equity. The initiative focuses and aims in bringing together different stakeholders like governments, innovators, communities, development partners, donors to bridge the last between promising AI tools and their sustainable adoption in health systems, particularly in low and middle income countries. This month's session, From Use Case to Scale Culture, Embedding AI in Public Health Sector Practice, is familiar to many of us. A surge of AI pilots, impressive demos, but little follow through when it comes to system-wide scale and integration. One of the most important aspects of the 6-month webinar is our expected outcomes. So while we are looking at enhancing cross-sector understanding of the topics across learning and hearing from different experts of different regions, we are also focusing on producing actionable knowledge products. A single published report featuring 6 concise expert panel summaries and also a way forward, each capturing key insights, standout perspectives, and practical recommendations that have come out from different speakers in different sessions. So drawing on this, I would like to invite my colleague and co-host Eric from OECD to please warmly open the session and share your remarks. Thank you.
Well, thank you very much, Resham, and I am thrilled to see so many people here today. I recognize that in the glorious days of summer, it is hard to get away sometimes, and people are on vacation, so that you're choosing to spend your valuable time with us, I think is a sign to me of the importance of this work that we are doing between the OECD and PATH. For those of you who didn't attend last month's session, which was on designing AI for low connectivity and resource-constrained health systems, it was a fantastic session. I had more than 100 speakers. I'll drop a link into the chat because we did record and post the session. But we really talked about how it is so important to think about solving real world problems and investing in our people as much as we're investing in our tools and the technologies around AI. And I think one of the greatest insights that I got out of the session was that many of the challenges that are being faced by a lot of the low connectivity resource environments are many of the same challenges that even some of the better financed parts of our health systems are still experiencing, reaching every person everywhere, such that healthcare can truly be universally received without cost barriers. So I think it's really important that we reflect about what are some of the opportunities for the use of AI in health services to really be a massive accelerator of improved health outcomes for people, improved health economic outcomes for systems, improved innovation outcomes for researchers, and really about better health outcomes for all at the end of the day. As Resham already noted, today's session on scale, I do believe because of so many pilots that are occurring, as has been said, there are more pilots in healthcare than there are airlines around the world. The challenge that we have is the ability to scale the innovations that we have. And I know I'm really looking forward today to hear from our panelists and have a more dynamic session today with more interaction between the panelists and the audience and between the panelists themselves to really spark some more conversation and insights that we can have in order to help to accelerate the use of AI in health, as we all want, for the benefit of everyone. So With that said, I'll come back at the end when we're talking about the next session. But with that, I'll pass it back to you, Resham. Thank you.
Thank you so much, Eric. So, drawing on what Eric mentioned, as AI increasingly becomes a lever for digital transformation in public health, we're now seeing a shift from tech based, tech led innovation to policy led adoption as well. We're joined by a powerhouse group of speakers, leaders shaping the AI health interface from government ministries, global funding agencies, health innovation firms, implementation partners. And together, we will unpack what a scale culture really looks like and how we can move forward from fragmented pilots to embedding it in the public sector. We invite our audiences to ask questions through the Q&A box only. Please post your questions throughout, and we'll surface a few during the open discussions. Speakers, feel free to reply to the questions in the chat, to reply to the questions in the Q&A live, as and when you want to. And simultaneously, we would also request the audiences to introduce yourselves through the chat and feel free to engage with each other among the same channels. So let's begin. We'll start with the quick speaker introductions. Over to you, David. You can just quickly mention about your role, your organization, and a sentence of your involvement in AI and health space.
Great, thanks. And thanks again for the invitation to participate. Looking forward to the next hour and a half or so of discussion around AI. I'm from Australia in wintry Brisbane at the moment. And I work for CSIRO, which is Australia's national science agency, where I lead our digital health research program, the Australian Health Research Centre. 160 scientists and engineers who undertake research and technology development in the area of digital health, spanning from a lot in the interoperability space with fast healthcare interoperable resources and SNOMED CT, through to AI from genomics and imaging, natural language processing, and through to virtual care, and of course a lot of increasing use of generative AI. So looking forward to the discussion tonight. Thank you.
Thank you, David. Susanna, over to you.
Okay. Good afternoon from Barcelona, and thanks for the opportunity to participate in this session. My name is Susanna Aussó, and I am the Secretary of the AI program in the health system of Catalonia, created by our Ministry of Health in 2023. And our program embraces the whole life cycle of AI tools from conceptualization to implementation. And its core mission is to create a safe and enabling environment for the adoption of trustworthy AI, with the goal of contributing to the optimization of the healthcare system and improving health outcomes for the population. So it's a pleasure to be with you all today.
Thank you so much, Susanna. Scott?
Thanks, Resham and Eric, for setting us up for a wonderful and productive webinar. My name is Scott Mahoney. I am a Senior Program Officer for AI and Health at the Gates Foundation's Global Health Division. I'm a South African-trained medical doctor and based in Cape Town at the moment, and have a specific and particular interest in how we evaluate AI tools. And in particular, what are our metrics for success? How do we see impact from the piloting to scale transition? And really, what are the key enablers that we need to move into the scale phase of impactful AI tools? And really looking forward to diving into these topics with the panel.
Thank you, Scott. Anya, over to you.
Hi, everyone. Good afternoon from Geneva. My name's Enya, and I'm an advisor at Delft Imaging, previously leading Baby Checker, which is our AI-enabled ultrasound unit. And just very briefly, Delft Imaging has 100 years of expertise in medical imaging and radiology, with a big focus on making equipment portable and able to access the most hard-to-reach communities in the world. We work in 85 countries, all low and middle income countries, to eradicate tuberculosis, first and foremost. Most of our work is focused on TB and lung image analysis through AI. And more recently, we've been diving into maternal health with obstetric ultrasound and developing Baby Checker, which is an AI-enabled ultrasound that's now used in 12 countries. Thank you.
Thanks, Anya. Finally, to my colleague from PATH, DRC, Victor.
Thank you very much, Resham. My name is Victor Olubuku. I'm a digital health specialist at PATH, and my work evolved on helping African governments and health system in effectively using digital tools, including AI, ensuring that those tools are pushing for positive public health outcomes. And when we are looking at innovation, making sure that the innovation are sticking into the local context and responding to the needs of the main stakeholders that are health workers and also the patients. Thank you.
Thank you so much, Victor. Great. So let's begin with our opening round. This is for all speakers. One scaled AI or one critical enabler. Despite the growing number of AI pilots in public health, very few are sustained or scaled. From your experience, please give one example of an AI solution that has been scaled and integrated into a system-wide public health system. If not, then what are the most critical factors that determine whether the AI use case transitions into long-term system-wide adoption? The structure of the opening session is going to be that I'll ask David and Susanna first, then we'll have a 5-minute opening engagement among the speakers if anybody wants to chime in, and then we will move forward to to Scott, Enya, and then Victor. So David, over to you.
So in terms of widespread use of AI, look, radiology in general is way ahead of the rest of healthcare, I think, and it was great to hear some of Anya's work there. And I think there's many examples of AI tools in radiology helping with kind of limited and really constrained use of probably traditional medical imaging methods for a particular task. And so I think we can see a number of those in widespread use around the world. What of course is getting really interesting now is just with the use of generative AI and the technologies which those sort of things are allowing, is just the broader use, less constrained use of imaging and generative AI tools not in radiology. So we're seeing it expand out elsewhere across radiology, but then into other areas of healthcare with perhaps scribe. Certainly in Australia, the use of AI scribes in all sorts of settings is what is setting the real adoption speed race at the moment. But if you're looking at where AI is being successfully used in constrained use cases, radiology is a perfect example where it's really enabling a lot of efficiencies. The work that's now going on is going to take that to the next level, as we're seeing around the world the challenges of enough trained people in radiology to meet the demand. So, but then there's all sorts of areas which I'm sure we'll get into tonight.
Thank you, David. Susanna, what about you in terms of your experiences with the Ministry of Catalonia?
Yeah, well, in our case, we are currently at an inflection point, moving from pilots and proof of concepts to the effective integration of AI in the public health system. So we've launched several AI challenges which are competitive goals aligned with real needs of our health system. And regarding these needs, one major gap we identified 2 years ago was in primary care, where professionals often lack support in interpreting medical imaging, as David said. So we are now in the process of public procurement to adopt AI-based solutions for 3 use cases in primary care based on medical imaging. The first one is diabetic retinopathy detection. The second one is detection of several findings in chest X-ray, such as consolidation, pneumothorax, pulmonary nodules, etc., which is radiology, as also said David. And the third one is skin lesion detection, including the identification of the most epidemiologically relevant types of skin cancer. And soon, a fourth project for stroke diagnosis will follow. So although all these solutions are not yet fully integrated, we have come a long way over the past 2 years, starting with identifying the need, preparing the state-of-the-art study for each use case, and publishing the tenders. And now we received several applications for each use case, and we are considering and evaluating all these candidates, and we expect contracts to be awarded in October and implementation to begin shortly thereafter. To support this procurement process, we are also conducting validation studies using labeled data sets from our health system to assess how well candidate models perform in our specific context. And obviously, we also ask for full compliance with, in our case, European data protection law, medical device regulation, as well as AI Act requirements.
Thank you, Susanna. I think a lot of it we are also doing it in India. We're doing AI challenges. We're working a lot with different partners to understand what are the needs, how can we bridge those needs. And there are immense number of startups that are coming up with different innovations to address different public health challenges. So I resonate a lot with what's happening in Catalonia with India as well. I would want to open the floor to the other speakers if anybody wants to chime in quickly with what David and Susanna had to say. Anya.
Sorry, I couldn't find the hand up. So I put my hand up. Yeah, I think that's amazing. And Susanna, we also work in retina image analysis. We can definitely take that conversation elsewhere. It's always nice when panelists we can also connect in that way. So I would say a huge enabler for us has been, and I'm sure this will resonate with everyone. I mean, we're all different stakeholders here. Government partnerships. I mean, that is such a huge enabler from the get-go, especially now that the financing landscape is changing vastly in global health, especially in LMICs. We really need to be co-designing, co-creating from the get-go. And that's at the forefront of everything we've done for the past decades. I would also say that for us, when we first launched the now scaled CAD for TB, so computer-aided detection for tuberculosis, it's now screened over 25 million people now, and is the most widely published, adopted, etc. CAD of its kind. The enabler to get there was to know more about pricing and what is actually considered affordable and in which models of financing does it fit in. This is the topic that people often don't want to talk about in webinars, in conversations, in meetings, etc. It's important. We are a social enterprise, which means impact is at the forefront of what we do, but we do have to make revenue to keep innovating. And for that, the price has to be right. It has to be right for us. It has to be right for the government and the procurement agencies. And we, just in a nutshell, having a per reading scan was our key enabler. And that came from conversations with the primary funders. So we're talking about, Global Fund, USAID, talking to local governments. What works for you? How can we make our procurement and our pricing models fit into your structures? And how do we make sure that we're building cost-efficient innovations? I think that's been the biggest enabler for Cat4TB to scale and to become part now of like procurement catalogs that fit into government budgets. And that's the same approach we want to take with the ultrasound as well, but that will be a bigger challenge, I believe. A, because in 2025, everything's changing in financing, and two, because obstetric ultrasound is not tackling a siloed disease. It's maternal and child health, which is not a disease. And that's very confusing in terms of budget lines and financing and everything. So that's our next challenge.
Thanks, Anya. Now that you've already, you're touching on financing, the next webinar that we're having the following month is on financing the AI for Health ecosystem. So we are engaging in those kind of conversations, and let's touch on that later. But Scott and Victor, if you want to chime in on something with what our speakers have said, most welcome.
Yeah, no, happy to. Thanks, Rasham. I think some fantastic points raised. And when we start thinking about kind of examples of scaled AI implementation, I think we'd be a bit remiss to not mention what's hot off the press in the last 24 hours from OpenAI around the kind of Penda work that was done, which is a private primary healthcare network within Kenya. And they had integrated an AI kind of consult clinical decision support tool into their lightweight EHR system. Some very interesting results coming out of that. And I think a start in the shift, as Karan Singhal, who heads up health research at OpenAI, puts it, is a shift in this Overton window from skepticism to acceptability. And I think when we start thinking about that shift in the Overton window, we think about all the stakeholders that need to be part of that shift, whether it's policymakers, government stakeholders, academic partners, research organizations, and the kind of adopters themselves. And so that's something that really excites me. It's solving for a specific problem in LMICs, and because it's already embedded into a given EHR system, it's being utilized, we're able to see a very low barrier to adoption by the healthcare workers on the front line who, we have to remember are the ones that drive the demand generation along with patients in the self-care space around demand generation for the utilization of these apps. And these innovations. So I think some exciting things happening on the continent and in South Asia, and great to see in the chat the diverse representation from around the world from the attendees. So super fantastic to see that, and looking forward to ongoing discussions.
Thank you so much, Scott. Great. So moving forward, Scott, again to you, with regards to our opening question, is there any example that you would like to highlight in terms of scaling AI, or throw light upon certain critical factors that determine its transitioning?
Yeah, Rasham, great segue into a discussion around kind of what these critical enablers are that enable or constrain the transition from pilot to scale. And I think, I think back to, there was a paper published by Huang et al., which described pilotitis, which initially when I read the paper, I thought this was a new medical condition, but is actually just a condition of persistent piloting in LMICs. A super interesting perspective, which to this day, 8 years later, still remains very relevant in the AI space, where we see fantastic new shiny AI innovations, but the ability for them to integrate and be adapted and adopted within LMIC context, for example, remains somewhat bottlenecked by kind of key factors. And some of these factors to think about is really, firstly, as Enya mentioned, the co-design and user-centric approach, making sure that we are designing in collaboration with our intended users, whether these are frontline workers, ministries, community healthcare workers, or patients themselves. User engagement kind of at an early and frequent stage creates ownership and starts to mitigate resistance. I think it also feeds into some of the way that we frame up the supportive ecosystems that are required for AI scaling cultures. We need to see strong partnerships with governments, with academia, private sector, and civil society, as I'd mentioned. And funding agencies are also critical to sustainable scale up. We want to make sure that we are enabling high impact potential tools that serve to meet strategic needs of kind of global health demands. But we also need to make sure that we're convening the right stakeholders to ensure sustainability when, say, funders step out from that initial startup. And so having those governance models and sustainability models from the early stages is incredibly important and provides reassurance to governments as well, whether this is a project that's going to remain with the NGO, an NPO, or a private entity, or be transitioned to the public health system, like we've seen in Malawi with Chapatale Chapafoni and Village Reach's work there. There's a great need for that leadership buy-in, and it's really foundational to ensure that we're seeing broader strategic priorities are being met. It comes on to perhaps discussion points for later around what these AI policies and maturities look like within LMIC settings. But really important to make sure that we're aligning with policy and strategy early. And I think we see a greater propensity for adoption of these tools in countries that are more energized by the potential AI gives. An example of this is early adopters like Rwanda, Kenya, Senegal. And the foundation has also set up scaling hubs within Rwanda and Nigeria more recently to set up partnerships with governments and identify high impact potential projects that can be scaled within the government's own ecosystem. So really important to be able to align to that kind of thinking.
Thank you so much, Scott. And yeah, over to you, drawing more on the co-creation and co-designing aspect that you've already highlighted earlier. Would you like to throw some light quickly on Delft imaging and how you have been able to scale it through different countries?
Yeah, sure. So I can speak about the experience of Baby Checker, and just as a heads up, this is not a scaled technology, right? We have our first projects now with government, with county governments, engaging with Ministry of Health on the adoption, but we do not have a national scale up. So I just want to kind of set that expectation. So even though our other AI products like Cat4TB have been scaling in many countries, Baby Checker is still on that brink so far. We have a good amount of evidence base from the past 7 years. We have done several pilots. We have now strong partnerships with government bodies, but I wouldn't say we're quite there yet. But what we've done to really prepare ourselves to get there is to really co-create from the get-go. So how we did that is a lot of go, no-go points in the development process. So the first time I ever went to Sierra Leone, which was the first country we ever decided to pilot in the community health centers, main reasons being they have the highest level, or one of the highest levels, of maternal mortality in the region. It's an incredibly low resource setting. So in our mind, as product designers and solution developers, we needed to work there. We're not going to pilot something in the Netherlands or let's say in Lagos or Nairobi and then kind of scale it from there. We're really going to go for a resource constrained setting and work from there. So that's already in our way of working. Secondly, when we first came there, we had a prototype. It did not look like what you see Baby Checker looking like today. But before taking it out of my suitcase, what I did was I learned how to palpate. I learned what it's like to really be a CHW trying to figure out the gestational age. Because if that was an efficient method in terms of accuracy and the time that it takes, then why would we build AI for it? And so that's really just to highlight also how we work as an enterprise throughout all these solutions is, yeah, we have ideas and then someone develops a PhD and there's a few publications that come out of it. But at that point, what we have is still an AI model that's in a publication. What it takes to actually turn that into a solution is usually years of work in terms of not just putting that model that's in a nice publication into a smartphone that works offline and doesn't have a lot of storage, because you also want to buy a cheap smartphone, not an iPhone with a bunch of storage. It has to be able to be procured easily. So there's been a lot of go, no-goes in that whole product development journey that really work closely with the health workers. So from learning, okay, what's the actual difference between an ultrasound scan detecting gestational age, for example, and a midwife using her two hands, to then validating that, okay, even if we made an ultrasound solution that uses an image that sends it to a sonographer, that takes 7 hours. When I was working in the middle of Sierra Leone, just sending that ultrasound scan took 7 hours. So the two hands was not very accurate, was also taking a long time. Sending a scan for 7 hours, not an efficient use of time either. So then you start leaning towards, okay, could AI actually help us in doing this and that, not just in detecting images, but in terms of making ANC more efficient. So antenatal care as a whole, not just the scan, but is the waiting room getting emptied if we introduce something that's more time efficient? So looking at things in a very multi-dimensional way instead of just being, AI focused, let's say. I think that's really been a key for us.
Thank you, Anya. I think multidimensional and also very multi-sectoral, because usually governments, certain departments, they function in a very siloed manner. But if we are looking at system-wide integration, there needs to be a coordinated efforts across different departments and ministries. Victor, over to you finally with your on-ground experience across so many countries. Would you like to throw some light on the opening question?
Yes, so from my side, based on the experience that I've got around Africa and other regions over the globe, I will be aligned with most of what my colleagues have said so far. And what I can just add is that whatever solution we bring or whatever product, AI product we bring, one or two of the factors that we usually look at are, for example, the usability and the context fitting of the design. So making sure that how the system will be used in DRC, for example, may be different in Malawi or in Sudan. And when we're looking at the context of the design, it can be small things like your geographical categorization, where in one country they have province and another country they say region. So those small things that can be sometimes forgotten are things that will allow for the health workers to empower themselves with the tool and take ownership of the tool. On the other side, it's also with the context, making sure that we show value straight away. So the health worker can see how the tool is bringing value to the work in a way of either decreasing the time, the task that they're taking, or improving the outcomes for diagnostic or for the reporting or everything. So as soon as the value is really located and localized for the end user, it comes with the appropriateness and the ownership, whereby the tool will then be used in a better way compared to, as Enya mentioned, just bringing a tool from a suitcase and hoping that it works in a certain way. Yeah.
Thank you so much, Victor. I want to just have a quick round of engagement if any of the speakers would like to chime in here.
I think there's been some fabulous examples given already, so looking forward to hearing more. Just a couple of things that come to me is, and from what we're seeing, one is, I guess the adoption of these technologies, both broad and narrow, is enhanced by local infrastructure. So. And particularly digital health infrastructure, as we see national health records and the ability to share standardized information about patients to support patient movement, which means that the data can go into algorithms, and algorithms can use data out of electronic health records and things in a way that enables the correct functioning, I guess, of the AI algorithms. We're doing some work in the Philippines at the moment around enabling and building capacity for the use of digital health standards, and particularly fire and smart on fire. And the whole smart on fire launch is an example which really does enable us to plug in AI algorithms to local infrastructure to support hopefully faster adoption of the algorithms than we've seen in the past. So there's a lot happening in that standardization space around the world, and it's not just fire. There's open air and other things as well, particularly in Europe. But that does enable the adoption of the algorithms in a faster way. The other thing is that the capturing of the standardized data in country means that hopefully we've got better data to be able to localize AI algorithms with standardized data as we take them from country to country. So I think there's lots of opportunities. So looking forward to hearing more. Thanks.
Thank you, David. Great. So I do see a lot of keywords: localization, contextualization, financing, co-creation, co-designing, all of these things which are very important. And slowly we move to round one, what it takes to institutionalize AI within the public health systems. So focusing on the mechanics of embedding AI into public health systems, what are the structural, behavioral, and procurement levers that enable scale? So David, let's start with you, with your experience with the Australian government. The Australian Department of Health, Disability and Aging has an AI transparent statement that explains how they intend to use AI technology and how they will adopt and use AI in line with Australians' public and government expectations. Also, Australia has seen a strong alignment between health research, public sector priorities, and digital transformation. So the question is, how has the Australian government embedded AI into the mainstream health policy and procurements, and what lessons can LMICs draw from that experience?
Well, I'd love to say that all of that's spot on. We're probably not quite as advanced as you made it sound, Resham. And I think the Department of Health would be very keen for me to say that the AI transparency statement, which you reference, is really about how the department uses AI internally, rather than how clinicians will use it at the coalface as part of providing care. And so without boring everyone with the details of how the Australian health system works, it is quite complex between our federal government and our state governments, and with primary care being offered by general practitioners in small businesses, really. And so so while the government does have an AI and transparency statement, we're still working on how AI should be adopted by clinicians. We do have a mature framework, of course, around software as a medical device and that regulatory side of things, which I think Susanna referenced earlier. And so we've got a very strong regulation of software as a medical device, and many AI products fall into that regulation of software as a medical device. So that's really the regulatory side of things. What we are seeing is most state governments, which run our public hospitals, which offer probably 70 or 80% of secondary and tertiary care in Australia, are really putting in guidelines around implementing AI broadly. And again, as I mentioned earlier, AI scribes probably after the traditional radiology and other applications, we're seeing the AI scribes as a big one, where people whether it's in emergency departments or our general practices are using to really help with the documentation side of healthcare. And really at the moment they're not regulated, and so that's one area where following on from NHS case last week around AI scribes as software as medical devices, we're starting to look at how we measure the quality of these things. With large language models, it's probably quite easy these days for software to add on an AI scribe functionality, but we do need to be careful to make sure that the quality of these tools are going to be high. So what the Australian government is looking at is localization of AI and how we go about that. I really loved, I think, Susanna's talk about AI challenges. I think Anya mentioned them as well. I think those sort of approaches can really do a lot in providing confidence to clinicians and patients, of course. Clinicians and patients about the quality of the tools that they're starting to use. But more than that, they actually really provide the opportunity for the field to advance quickly, which I think is some of what Anya and Scott have been talking about too, in terms of how we actually ensure that the products coming through are of high quality. So at the moment, the Australian government, to finish off, is really probably still looking at getting the fundamentals right in terms of good data. We now do have a national shared electronic health record platform. We're talking about and we're putting in place the FHIR-based standards to enable exchange of data across many settings that patients turn up. We're aligning that with the international patient summaries to support future use of shared data, and the government's now looking at how we support high quality use of AI across the healthcare system.
Thank you, David. I think one key takeaway is definitely having the Ministry of Health adopt an AI transparency statement within itself is a great takeaway for somebody coming in from an LMIC as well. Susanna, in your role as a secretary, Catalonia has developed a structured AI program for health embedded within the public health systems. So what institutional mechanisms and bureaucratic mindsets or behaviors have proven most effective in moving AI from experimentation to routine practice across the public services? And what are the main conclusions from the first years of the model operation?
Okay, yes. We've implemented 3 complementary institutional mechanisms. The first one is what I mentioned before, the launching of AI challenges that are public calls that respond to real health system needs, where companies compete to provide AI solutions that meet high technical, ethical, and legal standards. The second one is that we support bottom-up initiatives emerging from the research centers and hospitals, which have strong scientific potential but may lack the frameworks to become system-wide solutions. So we provide methodological, ethical, and legal support to ensure these tools can evolve responsibly and potentially scale across the health system. And I think that these mechanisms help bridge the gap between research and real world implementation, and also reinforces our AI ecosystem. And the third one is that we've created an AI observatory for health, that it's a key instrument that allows us to register and track AI solutions in Catalonia, developed or deployed across the system. And today, the observatory contains over 180 initiatives in different stages of maturity, from early research to market-ready applications, and it helps us to identify trends, promote synergies between institutions, and also reducing duplication effort. And about our lessons learned after these first years of the model, I think that several important lessons have emerged that maybe we've been talking before, but the first one is that prioritizing real system needs is essential. We've learned that the greatest value of AI often lies in redesigning workflows, improving coordination, optimizing processes, rather than only supporting clinical decisions. And now we are in the process of evolving our need identification and prioritization mechanisms to ensure even broader stakeholder participation, including professionals from across care levels, technical experts, patients, policymakers, etc. Another conclusion is scalability and sustainability. And I told this before. We must build it from the start. It's crucial to analyze how each solution could realistically be adopted and maintain it over time. Another conclusion is that the public procurement processes must evolve because of the rapid pace of AI development often exceeds the flexibility of traditional contracting. So we are exploring co-design models between health system and companies. And finally, the clinical leadership, I think, is essential. For each challenge, we appoint a clinical lead and build multidisciplinary teams that include health professionals, data scientists, legal advisors, and procurement experts also. And that's all. I think, in short, I think that embedding AI in public health practice requires more than innovation. It demands strong governance, cross-sector collaboration, and a commitment to system-wide transformation.
Thank you so much, Susanna. I think the key takeaways that I can get over here is the strengthening of governance systems within the Ministry of Health, where you're doing, where you've already established technical legal standards, where you're supporting the methodological and legal support to innovators for scale and having multidisciplinary teams. So I think this is great learning for us as well. So thank you. And Scott, moving to you next. You've been working with the Gates Foundation in the space of AI and health. So from your perspective as a funder, what are some common factors that enable or constrain the transition from pilot AI projects to broader public sector adoption? And what kinds of support or engagement have you seen make a difference in enabling continuity and scale?
Thanks, Risham. I'm really looking forward to answering that question, and I think we've touched on a number of those items in the kind of last sort of 40, 50 minutes. I'm wondering if I can be cheeky, and before answering that, I've just seen Mandy Govinder's comment in the chat, and I would really like to actually pivot to answering that because I think it's an incredibly important point. Mandy, I hope that you're still on the webinar, but so feel free to give us a thumbs up. But I think it's an incredibly important point, and would also love to hear David's thoughts on this and Victor's experiences. Just to reemphasize, Mandy's basically bringing up the point about are we not just going to repeat this whole process that we've seen in the digital health space with AI unless we, kind of address some of the root causes with the digital health space? But in addition, are we not actually going to see a compounded and multiplied disparity with AI implementation in the health space? I think it's a very bold point that we do need to think very creatively about, and it's been something that I've also been trying to figure out, in a constructive way. And I think taking a step back, there's two things that we need to just really address is firstly, the digital health space in LMICs has been something which has been difficult to move from pilot to scale because of pressing priorities, right? And it's been difficult for governments to justify spending on digital health technologies when they've got patients or people dying of malaria who need treatment, or under 5 mortality from diarrheal diseases and pneumonia who need to get into care and receive treatment. At that stage, it's also difficult to expect that a mother who is a small scale farmer and a mother of 2 kids that are being educated, for her to try and manage and self-care, as in high income countries might be able to do, for a child with a common diarrheal disease. And so digital health technologies were, utilizing deterministic processes, would require apps to be downloaded, possession of a smartphone, connectivity, power. And these are factors which also feed into major concerns around gender divides in accessing digital health tools, and something which is hugely important as we move into identifying biases and gender divides in the AI space. I think to also just identify that background, we now are contrasted with this disruptive technology. As I mentioned, the Overton window is shifting slowly from different levels of stakeholders. But we also have this exciting opportunity to leapfrog digital health systems in LMIC settings. David mentioned very clearly the national rollout through federal government and state governments of their EHR systems and improving interoperability. The fact is, in a lot of LMICs, the digital maturity to embark on something like that isn't necessarily there, or the ambition and appetite to do so with competing priorities hasn't been there. With AI now, the kind of entropy hump to start emboldening digital health maturity, because it unlocks so much more. It enables longitudinal health records for patients, which enables contextual memory for AI tools. It means that each person in the population can get a personalized health plan, that there's a really strong, lightweight learning health system that can enable patients to be better engaged in the health system. We also see AI as an opportunity through multi-channel access. Instead of now relying on a digital health tool or app, we can now utilize USSD. We can utilize phone calls, as we've seen with organizations like Viamo. We can utilize WhatsApp, as we've seen with Turn.io, as channels of communication, where all you need is an input, an identifier that links you to your record in the health system, and you receive an output back through text. Perhaps you may have difficulties with literacy, and so you can now receive it back in audio, whether a voice note or a live call. And so the opportunity to unlock access and reduce the inequalities is there. But we have to do so in a way which is managed with the right policies in the ministries in these countries so that we see the biggest effect. Anyway, sorry for diverting on that question, Risham, but I think in the interest of the audience and the community, it's so important. And Mandy, thank you for raising that.
No worries, Scott. I mean, this is what the webinar is about. Like, we want a lot of engagement with the audience and among speakers. Is there anybody who wants to add on this or answer to some of the questions that's been asked on the chat? Please feel free to raise your hands. Let me know. David, Susanna, and
I'll just very quickly say great thoughts, Scott, and agree with you totally. I think a couple of things. One is I think you can even go further and say that with something like the International Patient Summary, we as consumers, we as patients, can perhaps even increasingly hold that data on our own devices and share that as required, which brings even more, which takes it beyond needing national systems to having a level of independence for patients, which I think brings some different business models. I mentioned that we're working in the Philippines. We're also working in the Pacific as part of some funding we have from the Department of Foreign Affairs and Trade. And I think you're right in terms of, from what we're seeing, and it's the first time my group's really gotten involved in a sizable international project. And so what we see is a number of products in place which don't, which have obviously been funded through different mechanisms and don't talk the same language and can't share data and things like that. So what we're trying to do, instead of leaving solutions and building solutions elsewhere, we're actually working with the local health systems to raise the capability and understanding of what to ask for when they do get funding for digital health. And I think everyone sees the opportunities of AI to really improve their health system, but to do AI, you do need some digital health infrastructure. And so in some of the countries we're working with in the Pacific, they're not going to have multiple products. So interoperability isn't really the thing. What is the thing is having standardized data so that if they move from one product to another and bring in AI algorithms, they can work. And so that's where we're raising the capability of those countries, where in other countries we're actually raising the capability of the workforce who are building solutions. So but great thoughts, Scott. Thanks.
Thank you, David. Victor, given your experience of different countries, it'll be great to learn about your experiences in terms of behavioral and bureaucratic barriers that you may have experienced or your work may have experienced, considering PATH works in different countries in Africa. What are these barriers that have been experienced when we look at embedding AI into the public health workflows? And also not just about the barriers, but how have you navigated these challenges to move forward from a proof of concept to embedded practice?
Yes, thank you very much, Susanna. The barriers that we facing most of the time are categorized on one side as behaviors, and on the other side you have the bureaucracy. So when looking at the behavior barriers, you can face the resistance to change, where people are thinking that AI will come and take up their jobs, and they are not willing to get into that, or the fact that you will be using an AI tool means that you may have to change your framework or your workflow, and you can face resistance at that level. Another behavior resistance is the diverse level of digital literacy. And in countries like DRC and many other countries in Africa, when you leave the main cities, you start going deep in the country, you can see that the digital literacy is decreasing very abruptly. And that means that when you bring a tool that will be used in those local areas, the tool needs to be very intuitive. It needs to be very intuitive and not requiring too many things to be learned in order to start using the tool. Even though we do the hands-on training to teach people how to use the tool, but the tool itself needs to be very intuitive, whereby 1, 2, 3 you get to the result, or 1, 2, 3 you get to your data, and that can cover those different levels of digital literacy. Another behavior that we have seen is, I would say, the lack of trust, because we have been piloting over and over and over. So being at national program level or the health worker in the facility, they will tell you, oh yeah, you come in with this tool, but your colleague, that's how they usually say, your colleague were here 2 months ago, they brought us this device and we took 3 days of training, but now it's not working. And there is another organization that came last year. They brought other computers. You can even look, it's there in the cupboard. We are not using them and all of that. So at that moment, the trust is very difficult, and the people are not really willing to open to you and accept the tool that you bring in. When we're looking at the bureaucracy, we can see things like the silos that we have in different departments, and even in the Ministry of Health. If we go with the Ministry of Health, you have the National TB program, you have the HIV program, you have the malaria program. Each is doing its own thing, and the ministry itself does not have a very global or spread out hands-on on things that are done in those different programs or in those different departments. And with that, you can see that the national policies or a clear policy on AI is not yet adopted in the countries. Because if we have national policies, or at least a Ministry of Health policy for AI, it means that all the departments in the ministry will be following on the policy that we put in place. Another bureaucracy barrier that we face is the lack of investment on digital infrastructure. David and Scott have mentioned that part. We need to get to the point where the infrastructure where we are bringing the tools are decent enough to allow the tool to be working. So if we are looking at internet connection, we are looking at power issues, I would say all over Africa, we have those issues. And it means that we also need to look at those. Now, in order for us to tackle or to respond to those barriers, one element that we always put on the table is early engagement, being with different stakeholders at government level, at the ministry level, but also with the health workers, because they are the one who will be using the tool. So when you bring a tool, we do UAT, for example, user acceptance test, to ensure that the tool is responding to the needs of the users, making sure that it does not change too much from what they are used to and from what they usually do. We make sure that we can showcase the value that the tool brings. How does it resolve your issues? How does it simplify the task that you are doing? That will help in building trust very, very quickly and allowing the tool to be owned by the users. We also advocate for better policies and infrastructure. When we come as PATH, we can come as a technical advisor for a national program. So we will advocate for better policy, better infrastructure. When we're looking at the implementation, how can we make sure that the facility is the decent infrastructure for us to do the implementation? Nowadays, when we're looking at internet connectivity, we can choose solutions like Starlink that does not put us under the restriction of a telecom company and uploading data every month. So the coverage is good. When we are looking at the power issues that we have in Africa, we can propose solar kit panel to ensure that the servers, the laptops, the lights, or any other element in the infrastructure is well powered. And two other things that we we focus on when tackling those barriers is ensuring that we provide the right training. Otherwise, the tool will be there and people will not use them. So we need to tailor-base the training, and that we usually do after doing an assessment where it's either a facility assessment or a regional assessment to see what is the level of literacy and digital literacy in the region. At that moment, we know how we will structure our training in order to cover some basics for the training before we get to the level of training on the tool. And the last element will be iterative and phased rollout. That will give us an option to see what went wrong, what we succeeded in the first quarter or the first month, how we can make changes and make those changes very quick before we do a MOE after 6 months or a year. So as soon as we are doing those rollout in the phase level, or we do those iteration on the rollout, it really helps us to grasp any challenges that we can face and look for mitigation or apply the mitigation so that when we growing in the rollout, we are able to respond to those challenges and have a more efficient scale up.
Thank you so much, Victor. I think you've covered a wide spectrum of barriers and challenges that people face, not just in Africa, but in different low and middle income countries, and also how we can navigate through these challenges. And I think the beauty of failing sometimes is we learn from those mistakes. We learn how to, we get a lot of feedback from those people who are working on the ground, and then accordingly navigate those challenges in a better way the next time we do something. So that's how peer-to-peer exchange and knowledge exchange is so important. So thank you so much for throwing light on that. I just want to say, if any speaker wants to quickly chime in for this first round, please do so. And if not, then I'll move forward to the second round, keeping in mind the time. Okay, great. So moving forward to the second round, where we're looking at intentionally building a culture scale, where we're getting a little deeper and understanding what governance, validation, and capacity conditions are required to embed AI solutions system-wide. And some of these topics have already been taken up previously through different speakers. But I want to start with Enya, because Enya, you spoke about that you're still looking at a scale culture, you're still looking at scaling a baby checkup. So based on experience in terms of pilot projects that you have done in different countries, what strategies have proven most effective for innovators like Delft Imaging to engage governments early on, especially to align AI tools with public health workforce, public health workflows, to make it interoperable and have necessary procurement channels that align with your system-wide readiness?
Thank you, Resham. And I think this is a great segue from what Victor was saying, because I think in this panel, we're all wearing different hats. You know, we have technical implementing partners, research, funders, you know, government, and then we as like a company that's innovating in this field, it is our role, actually. It's our duty to fulfill a lot of the check marks that you just, you know, highlighted, Victor. And in the picture that's behind me, I mean, that's what AI can look like, by the way. When you do it in a co-designed way, when you really build it from you know the exact settings where you're intending your AI to be at, this is what, you know, AI looks like when you've done UAT, when you've done iterative co-design, when you understand the context, when it doesn't work with electricity or internet, by the way, and when there's a high uptake, a good amount of trust, only 3 minutes of training, and a good amount of intuitive design through implementing something like a simple traffic light system to really indicate high risk, middle risk, low risk, that's been designed together with the users. So this is what AI can look like. It doesn't have to be overly complicated. It can be, it can really work with the users, for the users, and be integrated into national programs. And then how we've worked with local partners to really make sure that that is the case is to, of course, understand what the current infrastructure looks like and what the needs are. And doing that needs assessment from the get-go, like I was saying earlier, is really, really important. So to understand what is the current status quo of how a specific disease or complication or health situation is being screened currently. So that's in our case, working in medical imaging. What is the current clinical or patient pathway for the specific area that we want to look into? So it comes when you're not just comparing your AI to the gold standard, which is, I think, obvious to all of us that that's something we do, but also comparing it to the status quo. And in our case here, Fatmata and Adama, the alternative to them using their two hands to palpate is not a clinical ultrasound. It's baby checker at this point. So it's important to draw that comparison as well between what they're currently doing and between baby checker, and then also the golden standard. So how we build that those local partnerships and that trust, and how we start to really have this interoperability and integratable mindset is really from building that evidence base from the very, very early stages. And then further along the line, with CAD for TB, so making sure that your AI is not, quote unquote, just detecting risks, which is already, novel and great in what it is on its own, but that it's also contributing to insights, analytics, that you're actually reusing all that data towards other purposes. And not we as a company, but the country, actually, the local stakeholders. So when we started CAD for TB in Kenya, CAD for TB was, quote unquote, just the first AI-enabled, chest X-ray image analysis tool for lung diseases. And now it's actually integrated into the national digital data infrastructure for TB surveillance. So that's how us as an innovator, as a company, that's how we want to further contribute to this from the get-go is again, not just to build sort of standalone AI software, but to actually understand what are the needs, what are the gaps in data and analytics that can also guide the like resource allocation, for example. If we are with Baby Checker, for example, already deploying smartphones that are in this bag, so there's a smartphone that comes with Baby Checker, let's leverage the fact that now every health facility where there's a baby checker in Sierra Leone or in Zambia, for example, there's a smartphone. So let's leverage it to input other data points as well. And then in the dashboard that we've built that is being integrated to DHIS2, they're basically now digitizing ANC. So always going beyond, our exact product mission, but also understanding what the strategic national alignment is and how do we actually empower and leverage our capacity, our knowledge, our expertise to drive into that direction as well.
Thank you so much, Anya. That was beautifully explained. And I think generating evidence onto how the solution is working and making it interoperable, making the system interoperable within the wide healthcare systems is something that is much needed. So thank you. Anya, while you have spoken from the grassroots realities, David, just zooming out in terms of a system perspective from policy and from a research aspects, you mentioned that Australia does have mature frameworks on SAMD and beyond. So in your experience, how can governments design validation frameworks? Because a lot of us are struggling to design validation frameworks for solutions so that they are contextually fitting into the local context as well. So how can we design validation frameworks that balance scientific rigor with the urgency of health system needs, especially when we are considering AI deployment in resource settings?
Yeah, look, I don't think there's many really good approaches around the world yet, which are really in place. Yeah, I'd like to hear a bit more from Susanna around the challenge framework that she's been setting up in Catalonia, based around Barcelona there, because I think that is the approach where where there are challenge frameworks that are open. They don't necessarily need to be around procurement, but I think we're seeing people, particularly from my experience in Australia, we're seeing the GP, the general practice, family practitioner sector adopting these tools without really any quality indicators of how well they work. And so a challenge framework around that sort of approach to enable them to see what they are procuring, even if it's done by a third party, is something which I think provides the opportunity for both innovators as well as those people who need to use the tools to get a good opportunity to see how well they work. So I think those are all still they're all still emerging. So very keen to hear more.
Thank you, David. Susanna, to you next. You've already spoken a lot from the governance aspects and standards that's been developed by the Ministry of Catalonia. What mechanisms has your government put in place to ensure system-wide AI implementation that can be used responsibly and safely across the health systems? And also in parallel, how are you approaching the growing reality that many healthcare centers may adopt AI tools independently, particularly Gen AI, without central oversight or sufficient expertise?
Okay, yes. In our program in Catalonia, we've adopted a dual approach. The first, structured governance for system-wide solutions, but also support and guidance for decentralized use cases, particularly where rapid innovation are at play. So for the first one, system-wide implementations, we've defined a set of technical but ethical, very important, and legal requirements for trustworthy AI that must be met before deployment. These criteria are aligned with PhixAi framework, which is an international consensus guideline for trustworthy AI in healthcare that comprises 117 international interdisciplinary experts from 50 countries, representing all continents in the world in which we participated. And these include criteria for technical robustness, validation, performance, etc., but also ethical requirements, bias mitigation, explainability, and so on. And finally, also regulatory compliance regarding data protection, medical device regulation, etc. So we also ensure that each solution goes through a formal evaluation process before the adoption. But as you rightly point out, we cannot assume that all AI use will be centrally controlled, especially with the growing availability of generative AI tools and easy to integrate third-party applications. So hospitals or primary care centers may adopt solutions independently, often driven by well-intentioned curiosity or local needs. So this decentralization creates real risk if not addressed, such as risk of bias, lack of privacy, misinformation, or even unintended clinical consequences. So rather than try to block this, our approach is to enable responsible autonomy. So first of all, we offer guidance and resources for centers that want to adopt AI independently, including guides on explainability methods, for example, but also best practices for generative AI in health, and guidance on the application of different regulations, such as medical device regulations. And second, we encourage providers to notify us in the AI Observatory when they are considering using AI, so we can advise them, and and if it's possible, coordinate validation, define metrics to evaluate the solutions, or share findings across the systems. And finally, across both levels, both systemic wide solutions and local initiatives, we are also designing an AI training plan for healthcare professionals and citizens, providing a structured education program that covers core concepts of AI and machine learning, but also specific content on generative AI, use case in clinical practice, and also a specific training for each AI solutions implemented at the system level for end users. So I think that these combined efforts seeks to empower professionals, enable informed adoption of AI, and build a culture where AI is used safely, ethically, and effectively, whether it's centrally driven or locally initiated.
Thank you so much, Susanna. When you talk about these things that you're doing, it makes me want to convince my boss that I should visit Catalonia and learn about what you're doing, so then we can accordingly embed these things into our work as well, the different countries. So I'm quite enthusiastic, and you may receive an email from our side for this. Um, Moving on to you, moving on to you, Scott. Feel free to pivot. Feel free to answer to any question if you want. But my question here to you is, how do you approach understanding the digital context or readiness of health systems when considering AI-related investments? And what signals or factors help inform your decisions about where support could be catalytic?
Thanks, Risham, and apologies for dropping off. My ISP obviously heard about connectivity issues and decided to show me a demo of it. So anyway, all systems back online. I think really interesting question. I think it's also a great summary to a lot of the conversation that's been happening, right? And so I think the first of maybe 4 or 5 points to think about when we look at the readiness of health systems and in the digital context is really many points that David has spoken about already is foundational infrastructure, right? So when we look at the digital maturity, internet access, ironically, reliability of power, and hardware availability. These are factors that Victor also touched on. And basic digital literacy is also an important component. You know, if we think we're going to roll out a digital system to enable AI, what are the healthcare workers' ability to interact and utilize these tools? It's something that is quite overlooked. I think there was a question in the Q&A around how we embolden community healthcare workers and healthcare workers in their literacy and training around this. So investing where basic readiness sort of exists or is rapidly developing does tend to catalyze greater impact, but we can't forget the basic fundamentals and the foundational infrastructure. In terms of evaluating the health information system's maturity, I'm sure David could speak to this better than I, but really the maturity of this underlying health system, such as your health information management systems, health information exchanges, lab information systems, should be relying heavily on interoperability standards and digital governance. But we don't see that in LMICs per se. We see disjointed data archetypes. We see disjointed kind of coding, utilization. And so we tend to spend a lot of time understanding how we need to do data transformations to get data to synchronize. The other issue around this is how asynchronous ready is the digital system as well. We expect that these tools and systems will work extremely well, but that relies on the foundational infrastructure. So all of these points interlink, because you can have a fantastic interoperable system, but if terminal A that the doctor is using in a clinical consult room can't connect to the server for the Ministry of Health because of connectivity or power, then a synchronous system will not provide the end effect that that user needs. So really an important piece. Then we also think about the local policy and kind of governance environment, which Susanna has been talking about quite importantly. Countries with existing digital health or AI strategies show us that there is an appetite to engage in AI tools. But that doesn't resolve the issues around regulatory frameworks and ethical considerations where AI investments, require these supportive contexts. And so this is a major issue that we're seeing in a lot of LMICs is that you have fantastic startups, pilots, but the question is, what if in 2 years' time, the regulator, where in many instances in health, is managed by a health products regulator, decides to step in and put in restrictions on what can and can't be utilized for all the right reasons. How ready is that innovator or tool to undergo that regulatory process? Are we generating the right evidence now on real world impact? Have we thought about our monitoring and evaluation processes and our governance of our tool so that we can satisfy the requirements? Are we thinking about the right ISO standards, the right marks that are needed for approvals from regulators? And so that's kind of a key component that needs to be done with almost an evaluation by design approach from the get-go. Another kind of component is what I touched on earlier is around human capacity and digital skills. AI scale-up is really deeply tied to human capital because it relies on behavior change processes. So assessments like Victor was touching on around user acceptability testing, health technology assessments more broadly are really important to consider what the workforce readiness is for these tools. I think we also need to be able to assess what the training needs are and what the realistic timelines are for developing this digital maturity and data literacy across the systems level. Something which is very overlooked is that we are trying to address the existing healthcare workers, which we have an 11 million healthcare worker shortage by 2030, according to the WHO. That's 5 years from now. It's not that far. It's a shorter time period than it takes to get through most medical school training programs. And so if every single tertiary education or higher education institution on the continent ran at full tilt for the next 5 years, we still wouldn't generate that shortage of 11 million healthcare workers. And so how do we make sure that the healthcare workers that we do generate are ready for an AI-enabled world? And so are we putting enough attention on improving that undergraduate curriculum as well? So kind of more broad thinking around that would be really helpful. Going to pause there.
Thank you so much, Scott. We have reached the 90-minute slot. If anybody wants to answer the open question by Sandhya, please feel free to do, Sindhu, sorry, speakers, you can answer it there. But I just want to take 2 minutes more. If anybody wants to drop off, please feel free to do so. If anybody wants to chime in quickly for a minute, we can do that, and then I will hand it over to Eric for the closing remarks. Okay, great. Eric, over to you.
Thank you, Roshan. I was actually starting to answer Sindhu's question because I was thinking about digital twins and the twinning that is happening around some of the health systems as opposed to twinning people. I think there's a lot of really interesting work that is happening in that space in terms of the next bleeding edge of things going on. But I want to thank everyone for attending. I want to thank our panelists for providing all sorts of interesting insights and being a bit provocative in what they were saying. I've learned about the Overton window, among other things, and I agree. I think that we are passing a transition point, which is quite exciting. But nevertheless, we are going to continue to do work with this work to summarize the session as part of a rural package. Next month, our session, as Reshma already noted earlier on, is on financing the AI ecosystem. This is enormously hard. It's all great to talk about the technology, but if you don't have money to pay for it, and the people and the technologies and the infrastructure, it's really for naught. And so understanding what the challenges are within there, I think is going to be really important. By virtue of you being here, it means that you're on a mailing list, so we'll let you know when it's happening. But we do encourage you to share this webinar with others. We will be posting this up on YouTube afterwards. And so again, please share as widely as you can, because we think that this is a really important topic for everyone to benefit from. So with that said, thank you. Thank you for the rest of your days, your mornings, your afternoons, your evenings, wherever you are. And thank you for waking up early, staying up late, or just having a nice afternoon coffee. So have a great remainder of your time and a great summer all.